who mainly focuses on women's health.
This meeting is being recorded.
Who mainly focuses on women's health and OB. Maybe I should restart. Assalamu alaikum. I'm Dominique DiLorenzo. I'm a family practice physician who mainly focuses on women's health and OB. Currently, I'm a Women's Health Fellowship Director with the Advent Health Family Medicine Residency Program. So this topic specifically is very important and near and dear to me and my patients that I take care of. I also have like interest in obesity medicine and really any like procedural stuff too. So there's a lot of other like topics that I hope to do present with. And then, so we're doing this virtually, but we also have some people with us in the hub. So I want to make it a little bit interactive, inshallah. Actually, Seema, can you get on the Zoom link?
Yeah.
So that way, like, you can see the text stuff, because I won't know. Seema's going to be like my manager here for the Zoom, since I won't be able to see anything because my presentation is showing. So. All right, so we're going to talk about abnormal uterine bleeding today, which is a huge topic. So we're just really going to narrow our focus to a couple of points. Disclaimer slide, I am a physician, but I may not be your physician. So please consult your doctor before making any healthcare decisions or guidance about specific medical conditions. And so we're just doing this presentation purely for educational purposes. And so hopefully women can help other women that may be going through some difficulties with menstrual bleeding. All right, so our agenda for today, we're going to talk about what is abnormal bleeding, specifically menstrual bleeding we're talking about, because to someone, normal may not be normal, and so vice versa. We're going to talk a little bit about endometriosis, and then also some alphabet soup, PCOS. So there's going to be a lot of words that people may not be familiar with, so I'm just going to do my best to really simplify everything and go over like some basic definitions and things that, you know, medical terminology and doctor verbiage that, you know, you might hear in the office or something. Okay, so when I was putting the lecture together, I was thinking about why do we really need to talk about this at all? And because I have medical students, I have resident physicians, something that I noticed is that, so I've seen physicians ask, are your periods normal? And the patient's like, maybe, yes, I'm not sure. And the doctor's like, okay, great. And then moving on to the next thing. So, you know, that's not really the story, right? The patient's not really sure if their periods are normal because they may not know what normal really is. And then maybe the patient gets home and says, oh, I forgot to ask, you know, the doctor if it's normal that I can't get out of bed when I'm on my period. Is there someone talking?
I think somebody's like baby or something.
Oh, okay.
Yeah.
So again, what's normal for somebody that they may have been living with their whole life, someone else will be like, well, that's not normal, that you can't get out of bed, that you can't go to work, that you can't go to school, that you can't function for that day. So then like another, hopefully this is the more correct scenario, is, you know, doctor says, tell me about your periods. And the patient's like, what? I don't know. What do you want to know about my periods? Why do you want to know about them? And so the doctor should then say, well, how often do they come? How many days do they last? How much bleeding do you have? What are you using during the time of your periods? Pads, tampons, menstrual cups, period underwear is really popular now. Do you have pain? Do you have nausea, vomiting, headaches? You know, are there any like symptoms going on during this time that are disruptive to your life. And then the patient's still like, maybe like, maybe, you know, like they don't really track their periods. Maybe they're not disrupting their life at all. So they're like, it pretty much comes once a month and it lasts for maybe 5 days. And that's kind of all, you know, that's the end of it because it's really not bothering them. So, and that's okay. We just want to make sure that, you know, we're getting all the information so that we can help the people who may not know exactly what's going on or what's normal per se. All right, so this is an example of a menstrual cup. I just wanted to put in that some people may not be familiar with. The great thing about them is they're really environmentally friendly. So meaning, you know, pads and tampons, they all go in the garbage. And so this is a reusable silicone cup. It's very flexible. And so basically, you know, I just put the image on like how it's placed. So it kind of folds in together and then it just inserted in the vagina similar to a tampon. And that little cup wraps around the cervix. And so any blood, you know, the cup will catch. I think the minimum amount is like 30 mLs that it holds. And the most is like 45 to 50 or something, which is a lot of blood. Usually they recommend changing out the cup once to twice a day, just not leaving it in for more than a 24-hour period. And then you would wash it after every use. And then like there's a sanitized process that's recommended too afterwards. So I just think it's a really great option that we don't normally talk about very much too. So, all right. So for my medical students in the room, this slide may be traumatizing. When I reviewed it, I was like, oh, this cycle that controls our lives. And when you're in medicine, you have to remember all of these ups and downs and hormones and changes and triggers. And so I just want to kind of express here that, you know, the period in general is a multi-system process. So it's not just like the uterus, the vagina, the ovaries, you know, it starts in the brain. And so, you know, thyroid can affect it. So we have this like multi-organ system really that any of these things can make changes to the menstrual cycle. Fat tissue in itself can cause changes and produce hormones and signals that disrupt this cycle. So there's a lot of different things that can cause this to be disrupted. But this is the basic, you know, what we expect to happen. So you have this, so if I can use my mouse here. So that where the period would actually start, where this is showing like this is the endometrial lining, or like the lining of the inside of the uterus is actually shedding, and then it slowly starts to build up again, and then it sheds again to have another period. So, you know, most or many people, I will say, have like a 28-day cycle, and so that's what's showing here. If it's longer, there's certain, you know, time periods that may be longer in length, and we'll talk about like what length is normal and everything. And then you see here, so there's these different lines, and these are just each one of these hormones that help signaling in the process. So based on what's going on at a certain time, you have these hormonal elevations. And then whenever you have hormonal elevations, you might have symptoms. So all these things may respond to like symptoms like breast tenderness or headaches, or so maybe, you know, people say like, oh, I get a headache, you know, every time like 5 days before my period or something like that. So, and that may be due to this progesterone elevation here. So why else do we care about abnormal bleeding? So I just want to mention that when I put in like group pictures of Muslim women, this beautiful picture up here at the top of the MWO is one of the pictures that came up on a Google search. I don't know if it's just because my I'm always searching MWO and it's already on there, but I thought that was really funny that if you put group of Muslim women, that our MWO is what comes up. So abnormal bleeding can affect 10 to 14% of women between menarche and menopause, meaning like, when they start when women start their menstrual period, all the way through menopause when 1 year after the periods have stopped. So I think this number is really low. There's probably a lot more, but a lot of women may not want to talk about abnormal bleeding. And then people who don't identify as women as well, who still have uterus and ovaries and anatomical similarities. So there may be, a lot of biases there. So this is kind of where we're getting into some of our alphabet soup and definition things. So I'm going to try to make it really simple. So amenorrhea is just no period. So and usually you consider amenorrhea once they have not had a period for more than 3 months. Oligomenorrhea is when means like infrequent periods. So if they're more than 35 days apart, and usually this is people that they're like, I get my period every 3 months, and they're not on any medication that would make their period come every 3 months or something like that. Or maybe every, it comes very like just like a long interval time period. And then metrorrhagia would be bleeding at irregular intervals or bleeding more than 7 days. So this is just irregular bleeding is the way I remember it. And that can be like if you bleed, like if you have your period and then maybe a week later you have your period again. And so that would be irregular, or if you have bleeding for like 10 days, then that would also be in that definition. And menorrhagia, I think that some people may be more familiar with, is just it occurs regular, like the period occurs regularly, so maybe every 24 to 35 days, but then it's excessive, so meaning in volume or duration. So these are like just some basic definitions, and we'll kind of go back to them if we need to. And then I have this little thing here, meaning these are more due to that ovulation cycle itself. So when the egg is released, these are more problems that occur somewhere in that. Menorrhagia will have its own problems and disorders that are associated with that too. So these are all possibilities for just the abnormal bleeding. Okay, so what is normal? So there was a lot of different definitions here. Nobody has a perfect definition, I think, but the consensus is periods that occur every 21 to 35 days. So meaning, again, that kind of every 28 days is kind of the most normal maybe. And then if the period lasts anywhere between 3 and 7 days, so anything beyond that 7 days would be either heavy or irregular maybe. And then changing the pad every few hours. So what would not be normal is changing a pad every 1 to 2 hours because it's soaked with blood. So that would be, very, very heavy bleeding. And then a tampon can be left in up to 8 hours. So there's no definition on like, how many tampons would you go through in a day for what's normal. And then for the menstrual cup, I mean, it shouldn't be filled up more than 1 to 2 times per day, basically. So again, they hold quite a lot of volume. So the total bleeding time, like, so if your period is 5 days long, the total amount of blood that you should lose should be between 30 to 50 milliliters. And that's like this cup is like 30 milliliters. So it's just putting it as an example, or 2 to 3 tablespoons of blood. So that would be for the whole period. So that can be kind of hard to quantify, like what is just blood, because you also have like other fluids, discharge. So you may, have blood in the pad or the cup, but how much of it is actually blood and how much of it is just normal discharge. So that can be kind of difficult to quantify. And I think that's why I had a hard time finding real definitions for it. Other things that are not considered normal, so bleeding or spotting in between periods. So you get your cycle every 20 or 30 days, and then, but on days 10 to 12, you're bleeding. So that would not be normal. Bleeding with sex is not normal. And then if again, you have more than that, 5 tablespoons or 80 milliliters blood loss. Again, how are you going to quantify that amount? I don't know exactly. Again, the cup is probably the closest way to quantify. So we kind of, you can break up what is abnormal into some different categories, but I like to think about it with problems with ovulation, meaning problems, with the egg releasing versus the ovulation is normal. So for problems or disorders where you have normal, like the egg and everything is functioned right, you'll have menstrual bleeding at normal intervals. So again, you get your period every 28 days, but maybe your period lasts 8 to 10 days or something like that. You feel like you're just bleeding a lot. And so this can be from a lot of different issues. And then where you have your ovulation problems, this is kind of where we're going to talk about like PCOS or polycystic ovarian syndrome, where there's problem like with the ovary or with the egg releasing or with that kind of hormonal response. And so that has its own bunch of categories too. So, okay. So again, these are all the things that can happen where you have normal ovulation, but you still have abnormal bleeding. So that regular periods, but they're very heavy. You can have a problem with bleeding disorders like hemophilia or von Willebrand's disease, or there's a lot of problems where you can have just bleeding, like a disorder like of the blood system. Thyroid can actually fall into both categories. A problem where you have like what we call structural things. So like you have your uterus, but there you have like masses on it that are benign, or you have masses on the inside. So all of those can cause your bleeding to be heavy or abnormal. And then you have your other category where you have your problems with ovulation. So hormonal triggers. So where you have like PCOS, which is where we have these like the insulin level can be high. It can cause problems with weight loss. There can be thyroid. There can be prolactin, which is like one of the hormones like for breastfeeding and lactating. That hormone can be elevated for reasons. So I just want to kind of point out from this, I mean, this is like a very like medical school and medical based topic, and it's like very difficult to kind of describe in like very lay terms, but that there's lots and lots of problems that can cause abnormal bleeding. So again, seeing your doctor, getting lab work, talking to them about what exactly is going on, so they can get to the correct diagnosis. And then these problems that like with the ovulatory issues. So if for some reason like the signaling is not right, a lot of them can cause increased risk for endometrial cancer. So it's not just like, oh, well, I'll put up with the bleeding. It's okay if it comes when it comes, whatever. It's really important to get some of these conditions checked out because they can increase your risk for cancer. Okay, so PCOS. All right, so I'm not sure if you all on the Zoom can read this slide, but I'm actually going to go ahead and read some of it because I really like the description. So PCOS, or polycystic ovarian syndrome, is the most common endocrine disorder in women. So again, the endocrine system, we're talking about like the thyroid gland, the ovaries, that part of that system. So it's the most common disorder for women. So that's huge. I mean, and I find women that I see every day that have this, and then they're not being diagnosed until they're like 40 years old or something. So a lot of times it happens much younger, 16, 20 years old, maybe 30. Maybe people have problems with getting pregnant because of this. So it's really important. With PCOS, the ovary itself makes hormones, and these hormones, sometimes it makes more of the male type hormones, which are the androgens. And so high levels of these affect the development of releasing the egg during ovulation. And then there's also formation of what we call these cysts on the ovaries. So if you go, let me go back for a second. So, here's our ovary. This is what we're talking about here. And for some reason, what will happen sometimes with PCOS is you have multiple of these kind of follicles that develop, but they're not developed correctly. And, the diseases we're going to talk about today, we don't even understand some of the process and some of the reason of why these things happen, which is fantastic. So anyways, so you have all these little follicles or cysts sometimes, and sometimes there can be hundreds of them. And sometimes there can be, one really large one. And that still may contribute, to this disease process. And so sometimes you'll meet somebody and say, oh, well, I had a cyst, but they didn't do anything about it and it went away. Well, I would still want to find out, more about what their bleeding is like, if anything happened, looking at maybe an ultrasound again to see if they have if they have a bunch of little cysts. So insulin is believed to be linked to PCOS. Again, don't know exactly the mechanism there. A lot of women with PCOS tend to be overweight, but some can be normal weight too. Many can be normal weight. And so with people who are overweight and obese, that can produce by itself, like the fat can help produce like a higher insulin level. But PCOS kind of does that on its own as well. And then because of the insulin level being elevated, this can, predispose you to pre-diabetes, diabetes, and heart disease, high cholesterol. All of these other problems can kind of go hand in hand with this disorder. And so one of the things it says here is it's commonly undiagnosed or misdiagnosed. And it's really important to know and diagnose this disease so we can help improve symptoms. And so it's believed that maybe 1 in 10 women actually has PCOS. Again, I think, this number is probably more accurate because if you go back to that other slide, if we're saying almost 10, only, if 10% of women all have abnormal uterine bleeding, but then we're saying 1 in 10 women has PCOS, that math really doesn't add up, right? So, probably a lot more women have abnormal bleeding disorders, and then, definitely a significant amount of those have PCOS and endometriosis. And both of these really are very, very underdiagnosed. So what are some of the symptoms? So like I had said, infertility can be a problem, having irregular periods. So one that I hear really often is like the in frequency. So every 6 months, or, I haven't had a period in 4 months or something like that. And sometimes it's like, okay, well, that's great. But then when they have a period, the period may be very, very heavy. And so that really, they don't know when it's going to come, and it can really be disruptive to their life. They can have the ovarian cyst, and so these cysts can get very large, and they can burst, and they can cause a lot of pain. So it can be a lot of like pelvic pain and abdominal pain. Hair growth. So hirsutism means like abnormal hair growth or male pattern hair growth. So they can have facial hair, like mustache, kind of chin area, hair on the chest, hair on the abdomen. And so, for some women, this can be very disturbing for them and disruptive to their life. A lot of times, like laser hair removal may not work as well. So that can be really aggravating. We talked about like the weight gain or obesity, so they can kind of go hand in hand. Acne is another big one. So we have a lot of like treatment regimens that's, will specifically, if the acne is the only problem, we can kind of target that. Thinning of the hair. So even though there may be abnormal or extra hair growth in other places, like the scalp may be thinning. Dark skin patches, that's kind of relates to like the insulin level too. So I mean, as you can see, this is not just like a pelvic, uterine, vagina problem. This is like everything kind of in the body, right, can be affected. Mental health, anxiety, depression, and then sleep apnea. Sorry. And so sleep apnea is like where you kind of like stop breathing at night. So it's especially affected because you can have like you can be very tired and fatigued during the day from it. And so it's something, that we definitely want to get checked out. And so just having PCOS, you may need to see, more than one type of doctor, because all these things can kind of just go hand in hand. And then women with PCOS are at risk factors for other problems. So I kind of mentioned those, like heart attack, high blood pressure, stroke, diabetes, and then also mental health things too. So like anxiety and depression. And we talked about too, there's definitely an increased risk for endometrial cancer here, because that uterine lining, so like that inner lining, is not shedding regularly. That is what can predispose you. So sometimes it's really important for young women to be on birth control pills or hormonal replacement therapy to get those hormones corrected, so that way they're not we're not increasing their risk for endometrial cancer. And so this just shows that everybody cares about this, so cardiologists included, because the risk of heart attack is higher. So this is like a disciplinary thing that all medical professionals should really care about this disorder and pay attention. And then this is kind of just how we get to the diagnosis. So there's a little bit, there's a criteria that physicians use. And so, but again, always talk with your doctor and see, like, based on your symptoms. But if you have some of those acne and things, basically if you have 2 of these, that can pretty much point to a diagnosis of PCOS. So 2 out of these 3 points. So the hyperandrogen, or the irregular menstrual periods or absence of the period, or if you have ultrasound finding with cystic ovaries. And then there's a lot of different treatments that can be used. So metformin can help in a lot of ways, especially keeping that insulin level lower. So again, maybe even somebody who doesn't have obesity or overweight, just the PCOS alone, keeping that insulin level so they don't get prediabetes or overweight or something like that, can help. OCPs are oral contraceptive pills. So we're talking about like birth control pills. A lot of times they'll say hormone replacement because we don't want to say, we're not using it as birth control. We're using it as like treatment of this disease process. And then these spironolactone and these drugs here kind of are for the acne and hair growth. Sometimes even like dermatologists will prescribe them. And then there's this is the hormonal IUD. So an example of that one would be the Mirena. It can help, again, make the periods regular, make sure the lining is regular and not increase. It helps decrease the risk significantly for the cancer there. And then I just put these in because you can have the fertility issues with PCOS. And so these are 2 medications that can help induce ovulation and help to get pregnant. So, all right, endometriosis. So this disease is extremely complicated at the medical level. So again, it's something that we don't really understand fully. So, it's kind of like, how can someone diagnose you with something sometimes if we don't even really understand this disease process fully? And we're always still finding out new things, but there are certain things that kind of like really point to this disease. So one particular is the heavy bleeding. So any women with heavy bleeding should really be evaluated for endometriosis. And then the other is pelvic pain. So any women with, if they're diagnosed with chronic pelvic pain or persistent pelvic pain or anything like that, they have every month their period comes on, they can't get out of bed, it's just debilitating, they can't go to work, they really need to be evaluated for endometriosis. And what this is this disease basically is just this endometrial tissue is not where it's supposed to be. So it can be in this uterine cavity still, but it can be like a growth of it. It can be outside of the uterus. It can be on the ovaries. It can be on the fallopian tubes here. It can be on the top. It can actually, I didn't put an image in here, but it can be on the liver. It can be on the lungs. It can be on other places in the abdomen, the rectum. It can cause a lot of problems, and especially the significant pain. Again, we don't know exactly why it occurs, but for some reason, it's tissue that looks like the inside of the uterus is not growing in the right place, or it's growing too fast or too large, and this can cause things to stick together. So like our picture here of the uterus and the tubes and everything, this is all like a very movable structure. It's just kind of like it's floating around, it's suspended by like ligaments and vessels and stuff, but it's mobile, it moves. And it moves, right? So like it changes a little bit when you have a period. When you get pregnant, it's going to grow, and so we need it to move. But with endometriosis, sometimes what can happen is everything gets locked and it sticks together. And that can create a lot of the pain problems that happen. So that's why, painful period on here is number one. Again, infertility is a big one. So not being able to get pregnant. Pain during sex is another big one I ask about, because these women, often nobody's asked them about pain during sex. And so that is a very good indicator of endometriosis, although there's lots of other things that can cause pain during sex as well. And then the bowel problems. So sometimes I'll ask if they have pain, going to the bathroom when they have a bowel movement, because there can be that tissue can be on the digestive system basically too. And so that can cause pain and problems. And again, this can, you can have ovarian cysts and you can have like multiple things going on here. So this slide, says the largest women's health crisis of our time, and it's really because it can be a very difficult diagnosis to make as a physician, and a lot of people are not educated about it. And so recently, when I was in a lecture, people were talking about how sometimes you really have to be your own health advocate, and you can't just depend on your doctor. And so that's kind of why we're talking about all these things too. Is like maybe somebody, maybe your sister, maybe your aunt. You're like, oh, that's what's going on. Like I really think she might have endometriosis, and so maybe you can help guide them and get them to the right person, so that way this can get diagnosed and taken care of. I think it's really important to note here that the average wait time for the diagnosis is 8 to 10 years. So that's very, very, very high. And, it costs a lot of money because a lot of times it's not diagnosed till surgically, but also it's ER visits, doctor's visits, trying to find out why you have this problem. Again, mental health things that can go into this, having pain for all this, many, many years, anxiety, depression, other pain disorders. So it can really affect these women's lives. There are different stages. We're not going to talk about them. It's just like the severity kind of the disease. And there's a lot of different treatment options. So just some myths and facts here. There's no cure for it. There's definitely treatments, but there's no, absolute cure that we know of. It's again, we're talking about abnormal bleeding. So this is again, one that's not normal. And then just because someone's pain may be very, very severe, maybe they don't have, it doesn't correlate with the stage of the disease. And so someone might minimize, like, oh, you only have, stage 1. I don't know why your pain is so bad. It's the pain doesn't correlate. So getting somebody who really understands that is important as well. Missing school or work, we talked about. Anytime you have bleeding, pain due to menstruation or anything, that's all not normal. And so, and what was the one I missed here? Hysterectomy or childbirth is a cure. So maybe some people have been told that. That's not what actually I've heard before. But that's not a cure, right? Because we talked about these endometriomas or areas of endometriosis can be on your liver, on your lung, they can be multiple places. Someone can have difficulty breathing even because of them. So it's there's, unfortunately there's no cure, but there are a lot of better treatment options. So again, cause, we don't know why it happens exactly. Maybe family history plays a role too. So maybe your mom or sister's aunt had also very, very, very bad periods, problems getting pregnant, that type of thing. How do physicians diagnose it? So maybe sometimes they can see something on the physical exam. So meaning either like, something with on your, like when they examine the abdominal area, or like on the vaginal exam, like looking with the speculum, maybe they can see signs of it. Ultrasound is another way. Sometimes it's picked up, sometimes by MRI, but really all of these things can be negative. And sometimes the only way it's detected is what we call laparoscopy. So what this doctor is doing here, so where you have a camera and you actually go into the belly and you look around in the cavity, and that can be a way to find the endometriomas. And you need, to actually take a biopsy of the tissue, so taking like a piece of it to make the diagnosis. There's no lab that can find it. So again, this is, unfortunately why it's very under diagnosed. And so there's a lot of research that's being worked on to try to find, labs or markers, or find, a way to make it easier to diagnose this, right? Because who wants to necessarily have surgery in order to find this, right? Most people would not want to do that. So sometimes based on the symptoms, we'll just go straight to treatment. We'll say, clinically, they have endometriosis. Most likely that's what it looks like. Maybe the patient doesn't want to have surgery. So we'll try some different medications first to see if the pain gets better, if their bleeding gets better. And then if it does, great, with no surgery, nothing to do, just keep using the hormonal therapies. Now, the problem sometimes becomes getting pregnant, right? Because you can't be on OCPs or birth control pills if you want to get pregnant. So sometimes coming off of it, there can be problems. There's some other medications here, like I don't know how to say this one even. I just say Orlissa, the brand name, Elagalix, I don't know. So this is like a newer medication. I've had some patients who have had a lot of success with this. And they've kind of done everything else and nothing else has worked. There's some other, like an intramuscular injection that can be used. And then surgery can actually be used sometimes to remove these areas that are found to have this endometriosis. And so there's like ablation, so that would be like maybe with a laser. And then there's also like surgical removal, so meaning like they actually will like take out the tissue with either instruments or like cautery tools. Or so that's a way that sometimes, again, it's treated, not necessarily cured. So any of the endometriosis can still return. And it, we don't know sometimes what rate it'll return at or if it'll return at all. Sometimes when patients have these other diseases like fibromyalgia, irritable bowel syndrome, thyroid, multiple sclerosis, lupus, chronic fatigue, Sjogren's, rheumatoid arthritis, asthma, allergies, and then they're having the problems with the periods, that may be another indicator of they may have endometriosis. So if you already have someone or someone with these diseases, then and you're also having problems with the periods and stuff, then you might want to think about endometriosis as well. And we didn't talk about for PCOS, so there's lots of these alternative treatments are the same for both. So like pelvic floor therapy, so this would be like with a physical therapist. There's manipulation kind of that they can do to help, massage even, osteopathic manipulation. So this is done by like a doctor of osteopathy, and there's like what we call visceral manipulation that they're able to do sometimes. So like we were talking about, sometimes the structures can be kind of frozen, and these manipulations can kind of help like release those structures that are frozen. Also, just help with pain. Like if you have pain there all the time, sometimes the muscles might become very tight. And so sometimes you need to like, somehow get those muscles to relax in order for that pain to be resolved. Acupuncture, just, exercise, there's heat therapy, electrotherapy, and cognitive behavioral therapy, because again, there's a lot of mental issues that kind of go into these, both of the diseases. So, and then my favorite thing is really lifestyle modification. So, what we're talking about here is diet and exercise. So really like moving towards a plant-based or anti-inflammatory type diet is really, really important. We think that a lot of these disease processes have something to do with inflammation. And so again, there's only so many things that, the patient or the person can do when they have something like this. And so diet may be something that they can actually do that's more natural instead of, a lot of the medications that can help with this. And exercise. So when we're talking about exercise, at least 30 minutes of moderate intensity. So example I like to give is like, if you're walking really fast, like you shouldn't be able to hold a conversation on the phone. You shouldn't be not that casual walking. You're like walking for exercise. And now, with the phones and the step counters and all that, you can use those to assist. So in timing and all that. But we like 30 minutes at least 5 days a week. So that's something that's kind of simple that can help sometimes. And then, there's people who can't walk or something like that. So swimming is great. So that aerobic activity is more what we're talking about here. And then diet, there's not one, diet that I recommend for everybody because everybody's body is a little bit different. But again, we're finding that more plant-based diet overall is really beneficial to health, meaning like getting away from milk and dairy and meats every day and that type of thing. So fasting, so intermittent fasting is a great way to kind of control your diet. And then the other one I wanted to mention too is like Mediterranean diet. So that is kind of a diet that I notice is very similar to like, a lot of cultural diets that people may already kind of eat. So sometimes that one is a good one to adopt. And basically, like half of your plate should be vegetables, so fruit and veggies, and then like 1/4 should be like carbohydrates. So we're talking about like wheat bread, wheat pasta, those types of things. And then the other 1/4 should be a protein. So like fish or chicken, preferably. So, or beans, of course, for our plant-based proteins. And that is my presentation. This is our last in-person meeting we had, so or like our last in-person presentation. So thank you. And I'm gonna exit. So if anybody has any questions on the Zoom call, you guys can go ahead. And how do I stop recording? I guess I need to do that. Whoops.
Click on, go back.
Okay, got it. And then pause.